Let's welcome our first speaker, Vahé. So Vahé is a principal statistician at the Office for National Statistics, and he's a research fellow at the London School for Hygiene and Tropical Medicine. His work on the relationship between ethnicity and COVID-19 mortality has had a significant impact on policy and has been widely reported in the media over the past year. Vahé, now it's your turn.
Thank you very much for this very kind introduction. So it is my work, but it's a big collaborative work with people from ONS, but also some of it with researchers from UCL and the University of Leicester, and I can even see some of them are here today. So I'm going to focus my talk today on ethnic inequalities in COVID-19 mortality and also vaccination coverage. So the two main outcomes that we've looked at ONS using linked administrative data. So obviously monitoring health inequalities is crucial for policy response, especially during a pandemic where response needs to happen quickly and policies be implemented rapidly. So having a very good feed of information and timely is very important. Existing data sources, so I'm talking before the pandemic, all had some limitations. So the one you could use are surveys, but the main issues, they do collect a lot of information about social demographic characteristic, health outcomes for some surveys. But the main issue for looking at ethnic inequalities in health, they tend to be relatively small, and that limits the amount of analysis you can do, especially when you want to look at an outcome that is relatively rare from a statistical point of view. On the other hand, you have electronic health records, which are great because they have very large, cover a substantial proportion of the population, and they contain very detailed information about the medical history of people. But they do tend to lack detailed information on social demographic characteristics and ethnicity. Although recorded, the quality of the information on ethnicity can be sometimes questionable. So what we did at ONS was to, sorry, I have typo in electronic health records twice. My apologies. Is to create a new data sources linking the census to electronic health records to explore health inequalities. And today I'm going to focus my talk on ethnic differences in COVID-19 mortality and the inequality in vaccine uptake. So before I go into talking about the analysis, I wanted to give you a bit of flavor of the data set that we've created, because I thought you'd be rather interested in that. So what we've done is combine the 2011 census to the primary care records provided by NHS Digital. And what this ONS public health data asset that we've created for the COVID-19 response is essentially the intersection of the 2011 census and the primary care records supplied by NHS Digital. And all the linkage was done on NHS number, and that allowed us to link the census to mortality, but also to all other NHS Digital assets, such as the hospital statistics, the primary care records, but also the vaccination data later on. So what we have in this data set, we have a data set of about 40 million people aged 9 or over that were alive on the 24th of January 2020, which we use as the beginning of the pandemic. And we have data on a wealth of information about people. So we've got demographics such as age, sex, ethnicity, religion, main language from the census. We also have social demographic characteristics, occupation, and so that's all from the census. And then we have a detailed medical history that we derived from the primary care and hospital records. And we derived it in the same way as a Q-COVID risk factor model, that we use the same clinical codes. And in terms of outcome, so we had mortality, hospitalization, and of COVID-19, but also hospitalization, diagnosis in primary care for other outcomes. So if we want to look at the post-acute consequences of COVID-19. And now I should add, we do have the vaccination, first and second dose vaccination. So in terms of coverage, obviously our population is people enumerated at the 2011 census that were successfully linked to the NHS patient register. So you can see that the quality of the coverage is increasing with age, because older people tend to have been more likely to be enumerated in the census. They also have a more stable history of addresses and so on, so to have more likely to have been linked. And so we cover about 90% of the English population age 65 plus. So what we did in this study, so looking at ethnic inequalities in mortality. So here I'm presenting you the result of a paper that was just accepted. Is based on the enumerated in the census linked to the primary care records. So the initial release that we did last year was just based on the census and mortality. We didn't have any clinical records, but we have since then updated our analysis. So what we do is we focus on people aged 30 to 100, and with had to be enumerated in the 2011 census, living in England in 2019, and in a private household. And the outcome is the COVID-19 mortality death, so either in hospital or out of the hospital. And the way we define COVID-19 mortality is based on the mention of the ICD code, of 2 ICD codes on the death certificates. And we use Cox proportional hazard to estimate the time to mortality, and we have models stratified by sex. And what we do is we adjust sequentially for a different set of characteristics. So what we don't want to do is produce a fully adjusted model as a measure of inequality, because that would be wrong. What we do is we first adjust for age, and that is, if you like, the true measure of inequality, adjusting for age and sex, stratified by age, adjusted for age. And then what we do is can attempt to understand a bit the differences. We sequentially adjust for different set of factors and see how the estimated differences vary. So first we adjust for geographical variables because of the spread of the epidemic. So it spread more quickly in some areas than in others. So it's quite important to account for this. Then we have a bunch of socio-economic variables that we include. So IMD, so index of multiple deprivation, social grade, which is a measure of socioeconomic status, household tenure, household size, if the household is likely to be multi-generational, and so on and so forth. So factors that are believed to be associated with the risk of COVID-19 infection or death. And then we also adjust for pre-pandemic health factors. So we've got BMI and the comorbidities defined as per the Q-COVID risk prediction model. So here, what we do is we look at overall mortality. So we want to adjust for factors that are either related to the risk of infection or to the risk of death if infected. Unfortunately, with data we cannot separate the two. We can only look at the overall risk of mortality. So what we find, so here what I show is the hazard ratios for COVID-19 related deaths for ethnic minority groups compared to the white British population. And it's hazard ratios for 4 different models. And so in purple is the model adjusted for age and then adjusted for different factors. So you can see that all the ethnic minority groups were at elevated risk of COVID-19 related deaths in the first wave. And when we try to see which factors explained it, so a lot of it was due to geography. So when you adjust for population density and region, for most groups, it halves the estimated risk. So where people live mattered a lot. And then it was social demographic factors, so adjusting for that further reduced the differences. And what we find interestingly is that adjusting for pre-pandemic health doesn't make a massive difference once you've adjusted for the other factors. So it's not to say that it doesn't matter for the risk of COVID-19. It means that it's not the largest driver of the differences, at least after you've accounted for other factors. So most groups remain at elevated risks once you had fully adjusted, once you adjusted for all these factors, which means that there are other factors basically driving these differences that we don't observe. So it could be more behavioral factors that we don't observe, but it could be also that the factors we observe are observed with an error because they are based on the 2011 census, and therefore it attenuates the explanatory power of these factors. So we cannot rule out that the differences are fully explained by social demographic factors if we could measure social demographic factors in a better way. But what we can see is massive reductions, especially if you look at Bangladeshi men. So it goes from 3.5 times more likely to die to 1.4 when it's adjusted for men, and for women it even becomes not significant. So what we can see here is that a lot of the difference is explained by this a geography, social demographic factor to an extent. What is quite striking is when we look at wave 2, is the patterns of inequality that has changed dramatically. So here, wave 2, we only look at deaths until when we did the study, we only had deaths until the end of December. So we are producing updated figures that we will be publishing next Wednesday that covers deaths until the end of March. And the picture, albeit a bit different, remain relatively similar. So what we find is that the risk, the elevated risk amongst Black has reduced considerably to the point where, at that point in time, they were no longer at greater risk than the white population. On the other hand, what we found is that the risk increased considerably for people from Bangladeshi and Pakistani ethnic background, being Pakistani men being almost 5 times more likely to die of COVID-19 in the second wave than white British men. What is interesting as well is the effect of the explanatory power of geographical factors seems to have been reduced in the second wave, explaining almost no difference between Bangladeshi and white British, and there was still playing a bit of role for people from Pakistani background. I think the key finding from this is that the changes in the differences between wave 1 and wave 2, it does suggest that the difference in mortality is due to difference in infection rather than due to if people are infected, they are more likely to die. So it is likely to be an infection story, and in a way, it's a good news because it means it's far more it's easier for policy to act upon it. We can even hope to believe, at least, that all the policies and intervention that followed some of the early reports last year, that people from Black background were more likely to have died of COVID-19, may have helped raise awareness and therefore reduce the inequality that we observed. Another key finding, I think, from this study is that the difference in mortality are not explained by the difference in health. So again, that is driven by infection. And I think that was is as odd as what was initially believed earlier last year during the first wave of the pandemic, where the clinical factors were seen as the main explanation between the risk of deaths amongst ethnic group. So again, what this highlights is the need for policy to prevent infections, especially. So I'm not going to go into too much detail about this, but there are some policies that could help support vulnerable group so to isolate, for instance, and to reduce the risk of infection. Okay, so quickly, I'm not going to go through the work we've done on the inequality in vaccine coverage. So again, from a policy point of view, it's very important to know if there are any groups that are less likely to be covered by the vaccination program. So what we did is link the vaccination data that we receive from NHS Digital to the ONS public health data asset. So here for the 50+, we achieve a linkage rate of 86%. So that reflects the fact that not everybody who gets vaccinated was enumerated at the 2011 census. And was successfully linked to the patient register. So here we've got a bit of a non-linkage. So it's quite reassuring to see that the average age of the linked and unlinked people who get vaccinated was similar. And what we did is simply compute the rates of first dose vaccination by the 12th of April, 2021, and then also doing some logistic regression model adjusted for age and sex first, so to get the true measure of inequality, and then to see if these differences are driven by other factors such as geography, deprivation, education, household tenure, and pre-existing conditions. So that's what the rates look like. So when we look at the vaccination rates of adult age 50+, so it's about 93% for white British and as low as 66% for Black Caribbean, and 71% for people from Black African background. So again, we see massive differences here. And when we looked at the vaccination rates by other characteristics such as deprivation, household tenure, and NSEC or education or any other characteristics, the differences are never as large as by ethnicity or religion. So that suggests that there's something going on in these groups that is not due to deprivation. And indeed, when you look at the odds of not being vaccinated, adjusting for culture, for social demographic factors and geography and other, does reduce to an extent the odds ratios, but not completely to zero. So they still remain at risk. So there is this suggests that there is something going on in this community that need to be addressed by policies. So increasing vaccination rate among this group is crucial, especially since we've seen that they were also more likely to have been at risk of COVID-19 deaths during the first wave for Black African, Black Caribbean, and during the second wave for people from Bangladeshi and Pakistani background as well. So boosting the vaccination rate in this population is particularly crucial because they are probably more likely to be infected. So there are some community-led interventions, lots of good work done by GPs and in vaccination centers to try to increase the vaccination rate. So we'll be continuing monitoring the uptake of this and rerunning quite frequently. And what we are going to do as well is looking at the attrition from first to second dose and see if some groups are also, if they have had their first dose, they may also be less likely to get the second dose. So that's all from me. So happy to take any question. I think that's how it works, right? Questions now?
We have 5 minutes initial question session.
Okay. So I can't see the chat because of sharing my screen, but
yeah. Well, actually, just after I listened to your talk, there's one question immediately coming to my mind, because you said actually the health condition, which is like the baseline information of each individual, is not significant. It cannot explain the difference in mortality. I'm a bit shocked by this fact, because I have expected that this is definitely one of the biggest issue.
So here I think there are health conditions are a very strong predictor of COVID-19 mortality. What we find here is that once you've adjusted for other factors, they don't really explain much. So one reason it could be because they are actually very strongly correlated with some social demographic factors. So if we adjusted for health first, before social demographic factors, we might find a bigger effect. So what we haven't done here is a proper mediation analysis that would properly separate out the effect of the different factors, just because of the number of factors that we look at. It's really difficult to do. But then, because the other thing is that it's also, it's health condition measured in clinical records. So it's not necessarily the underlying health that it captures. What it does capture is the underlying health plus willingness to have contact with the GP system, with the primary care system and the hospital system. So if some people never go to their GP, they'll never be diagnosed. So we don't capture undiagnosed conditions, I guess, which could also be a strong driver. So if some people have got undiagnosed diabetes, that could be really bad for COVID-19, but we wouldn't know about it because they wouldn't be in the, we would know they have undiagnosed diabetes by definition.
Right.
Yeah,
right.
It's also that like infection matters a lot here, because it's not among infections. So it's not among infected the probability to die is overall. So it's the probability of being infected times the probability of dying if you are infected. And I guess you can't die of COVID-19 if you don't get infected. So that's why maybe infection will be differences in infection factors that are related to infection will have very, very strong explanatory power.
Right. Actually, Vahe, I can see there are many questions not popped out in the chat, and I don't think we can finish it in this initial question and answer session. I will try to cover as much as we can, and the remaining questions we can deal with it in the later joint discussion session.
Yeah, and I can reply to some of them as well.
Okay,
yeah.
Right. It's from Michael. So will you be updating analysis by religion?
So the religion analysis was, we updated it 2 weeks ago. I think we published something. So I can send a link in the chat. For the mortality or...
For the mortality, I think.
Yeah. So we've updated it a couple of weeks ago. We've published it on the ONS website, so I can share that.
Okay. And from Andy, say the difference in vaccination may be masked by employment because the ethnic minorities more likely to work in the care sector. So what do you think about it?
Yeah, it's a good point. So that could be an explanation, but we do find the similar differences among the 70 plus. So if you just look at people aged 70 or over, we do find similar pattern, and then it's less likely to be due to employment, I guess. But I would have thought that if people working in healthcare sectors, they would have been vaccinated earlier because they would have been on the priority list. So, and is it because you mean that they would have a lower vaccination rate if they work in the healthcare sector?
I was thinking they'd have higher if they work in the vaccination, if they work in the healthcare sector, and therefore the difference may be underestimated. Okay, yeah, I get. That's a good point. Yeah, no, totally agree with that. So we only have the occupation from the census, and we didn't really analyze it here. But what we are hoping to do is have access to the 2021 occupation data very soon that we could add to our data set. And that will be very informative, I think. But yeah, no, you're right, it's a good point.
Okay, so Shumi asked, how did you choose these ethnic groups?
So our base is the 18 category that is asked as a 2011 census, the kind of official classification. And then we tried, it was guided primarily by the number of deaths that we had in each group. So we couldn't look at groups where, for instance, Irish or travelers, these groups were too small to look at in isolation. So it was primarily driven by the number of deaths and trying to make sense of that. Is there any particular group you think that we should be looking at, or?
Shumi? Okay. Anyway, because of the time. Yeah, sorry. Carry on.
Okay, I was saying that I wanted to understand what, like, how you come up with these particular ethnicities, and, for example, what did you include in the category other, and what did you include in the category mixed? I wanted to understand, because isn't there other issues such as, for example, these differences in cultures which may affect also, especially the vaccination uptake? Maybe differences in culture, but you have put them in the same group as mixed, or you have put them in the same group as other because maybe they were smaller representation in those categories. Doesn't that alter also your findings in a way?
Yeah, I mean, it's true. The other categories are always hard to interpret because of this kind of a residual. So the mixed would be anyone we've declared to be of mixed ethnicity. So it could be, I know what, Asian and white, or any combination of mixed that is people can come up with. I mean, it's a good point for the other, especially for the vaccination. We should probably try to break it down a bit more, because then we've got the power to do so. For the deaths, you can't really, because the individual groups get too small. But for the vaccination, it's a very good point. I'll try to, in our update, we could try to break down some of these groups a bit more. Thank you.
Because the differences in culture can also have an effect, not necessarily on mortality, but more of vaccination. Maybe culture and religion, because there's someone who also mentioned issues about religion. Thank you very much.
Yeah, so for the religion, we did publish vaccination rates by religious groups as well. But it's very good. So what we've done, to be honest with you, is we've we use the same category that we use for the mortality analysis for the vaccination, but it is true that we could probably try to see if we can produce more granular estimates. So thank you very much.
Thank you very much for your presentation. It's quite related to my own research, but it's not about COVID-19. So that's why I was interested. Thank you so much.
Thank you.
Okay, I mean, due to the time constraint, we have to move to the next session. But everybody is more than welcomed to raise questions in the final discussion, joint discussion session. So now I'd like to welcome James. So James Nazroo is a professor in sociology at the University of Manchester. His research focuses on inequality, social justice, and underlying processes of stratification regarding aging, gender, and ethnicities. So he is the founding and deputy director of the ESRC Centre of Dynamics of Ethnicity and co-principal investigators of the Synergy Collaborative Centre. So he's also the founding and co-director of the Manchester Institute for Collaborative Research on Aging. Now, welcome, James.
Thank you very much. I obviously gave you too much information to say about me. I'm very pleased to be here and very pleased to have the opportunity to talk about my approach to thinking about inequalities in relation to COVID-19. So my talk is very much about explanation. So it's not really a data talk, although I will show some bits of data, but not much. It's really about explanation, which then means thinking theoretically and thinking theoretically around ethnicity and what ethnicity represents in our society. And also thinking about policy. So how and why policy has or has not worked and how policy might be rethought. And as you can see from the title of my talk, racism is at the center of what I would like to say in my talk. I'm going to start by taking us back and back to before the kinds of analysis that Vahé shared with us to when the COVID-19 pandemic started and how the question of ethnicity appeared on our agenda. And so the emerging story of ethnic inequalities in relation to the pandemic was really about the ways in which the pandemic was initially seen as a great leveler. We are all at risk. Everybody's at risk of COVID, and because of the unknownness of the infection, we were all perceived to be at relatively equal risk or relatively equal danger. It was a great leveler. And variation in risk across the population was ignored in that initial public health discourse. And even according to age, it was ignored in that initial public health discourse. And we have seen some of the consequences of that in terms of what happened in care homes. Ethnic inequalities in outcomes were really only pushed onto the agenda when we began seeing pictures of Black doctors, Asian doctors, Black nurses who had died on our television screens when we were watching news reports. It was that began to push the question of ethnicity onto the agenda. And public health generally was very slow to acknowledge this increased risk. And my argument is that policy has not shifted in response to all of the work that's been done to investigate these inequalities over the last year and a bit. So even more important, perhaps, though we haven't seen the consequences of this, is that the policies that were put in place to manage the pandemic are acknowledged to have a negative impact in relation to a whole range of things, from the economic to the social to the psychological, and indeed in terms of health. We've seen how waiting lists have changed, for example, or we've seen emerging data on difficulty in accessing services. But we're not really, or we're only just beginning to think through what the inequalities agenda might be in relation to that. And that's in part because as the policies have been implemented, withdrawn, re-implemented, and again begun to be withdrawn again, we've had a narrative that suggests that on average, these harms are worth bearing because you can protect the NHS and thereby protect people who are seriously ill from COVID. But the on average doesn't apply to marginalised groups. Marginalised groups, including ethnic minority people, are at greater risk in relation to these harms. And towards the end of my talk, I'll just say something very briefly about this, but this is a crucially important issue that we, I believe, need to think about. Now, of course, we now know that the inequalities in relation to COVID-19 mortality are dramatic. And not just in relation to ethnicity, but as Vahé said, also in relation to religious minority groups. So what doesn't appear in the ethnicity charts, for example, are Jewish people who, in other work that Vahé and his colleagues have done, show a very high mortality risk as well. So those purple bars in the first wave analysis that we saw a few minutes ago are very, very large. When I began my work on ethnic inequalities in health in the 1990s, there was lots of concern about relative risks that were of the order of 1.3 or 1.4. Here we're talking about magnitudes higher risks in terms of COVID-19 mortality. So how do we set about explaining these risks? And I know we've been through this a little bit already. Just go through the narrative that we are offered in terms of the explanation for these risks. First is the greater risk of exposure, of course. And so the kind of occupations that ethnic minority people are more likely to work in, the kind of places they're more likely to live, increase exposure to risk. And this goes from healthcare work or transport work through to overcrowded housing and living in densely urbanized areas. Another strong argument in terms of explanation is the social and economic inequalities faced by ethnic minority people across a whole range of dimensions, from finances to employment, to education, and so housing and so on. And that these inequalities, we know from a very wide literature, not only shape the health of inequalities in health in the population in general, but also are crucial determinants of ethnic inequalities in health. They're very difficult to measure in their entirety, again, as I pointed to, but nevertheless, once you begin to measure them in their entirety, you begin to explain a large proportion of ethnic inequalities in health. And then the other dimension that has been discussed quite heavily is that of underlying comorbidities, and underlying comorbidities that then increase risk, increase vulnerability to infection and the consequences of infection, diabetes, hypertension, cardiovascular disease, are those I've listed there. There's also multimorbidity, which amplifies that risk, and discussions around things like vitamin D deficiency. What that leads to then is a discussion of biology and how biological differences across different ethnic groups might then lead to increased risks of mortality, and that slides into a discussion of genetic vulnerability, even though the evidence for that, of course, is non-existent. And then also a discussion of cultural vulnerability. We've touched on that a little bit, the ways in which particular cultural practices might increase vulnerability. So multi-generational housing and overcrowded housing, perhaps through choice rather than necessity, gathering in places of worship, refusing to socially isolate because the worship is more important than the social isolation, and so on. And all of these things have been important parts of our discussions around the increased risk. My argument is, as you can see from the bullet points, of course, that we need to think completely differently about possible explanations and consider what it is that ethnicity represents in our society, what it means, and then therefore how it shapes the lives of minoritized people. So that for me means a focus on processes that lead to the racialization of ethnic identities, and I'll talk about that in a minute. How that process then shapes life chances, and then takes us to what I consider to be fundamental causes. So the things that drive the factors that are at the top in the top three bullet points in my slide here. And that then requires a central consideration of racism and how racism operates to shape life chances and thereby inequalities in health. And I'll go through this process with you now, but or this process of reasoning with you now, but start with a discussion of what we mean by ethnicity, and to offer a theoretical rather than a common sense notion of what ethnicity is. So I draw here from two sets of authors. One is John Solomos, who's a UK sociologist, writing, as you can see, many years ago. And he talks about the way in which ethnicity is a discursive formation. This is something where we use language to name and explain and accord social significance to a category. So we have a common sense understanding of what it means to be Black African, what it means to be Jewish, and so on. And through that understanding, we then set about trying to explain differences. Now, this is not to say that the observed differences are not real. Of course, people have different religions. Of course, people have different phenotypes. But to make them particularly significant, to reduce them to absolutes, and to not consider the ways in which meaning is attached to them, and the ways in which how they play out in people's lives as a culture may vary considerably across context over time and according to other dimensions of our identities. And John then goes on to say what's important here is that this has consequences for people who are labeled in these ways. So these names, these ideas, these categories have meaning, which then has consequences. And he points to the material consequences that they carry. Emma Bay and Desmond are US scholars, and they talk to the ways in which value is attached to these categories. So the ways in which identities are perceived, valued, mobilized, used, and the ways in which we interact with them are shaped by resources associated with those identities. Economic, cultural, legal, political, and symbolic resources that we then draw upon to provide meaning in a varied way, in a valued way to particular identities. Important, they argue, is how emotions are attached to symbolic resources, emotions around risk, around danger, around fear and disgust, which then emphasize the value attached to those identities. They shape the practices of us as members of a society and of the institutions within which we operate and live. So this is a different way of thinking about ethnicity than a set of cultural practices, and I believe in a crucially important one. And then how does this connect with ideas of racism? So the question here is, what role does racism play? And my argument is that work on socioeconomic determinants of ethnic inequalities in health, the kind of work that people like me have done, typically focuses on individual risk. And individual risk operating on a basis of economic features like income, occupation, and so on. I've listed some on the slide. Exposure to environmental hazards. You can see how this translates into my earlier slide of explanations for differences in COVID-19 mortality risk. So exposure to environmental hazards, and of course there's a whole range of environmental hazards that impact on our health beyond infection. Socially inflicted trauma and how that affects our biology and consequent vulnerability, and the targeted promotion of certain types of consumption. But this is individualized risk. And what we have to understand is how these individualized risks are distributed across groups within the population. So that's my next point. We need to think about the ways in which these risks are patterned, and then think about whether racism and what role racism plays in shaping those risks. I give a definition of racism on my slide here, which I won't go through. It's a fairly standard definition, but my argument is that we need a conceptually robust approach to understanding how racism operates, how the racialized social order operates, and then how that leads to inequalities in health, and also how it leads to policy and practice responses to those inequalities. And so now I'm going to try and work my way through that and talk about the ways in which I approach an understanding of racism and the impact of racism on health. And I talk about three dimensions of racism. One is structural racism, the second is interpersonal racism, and the third is institutional racism. This is just a tool, a rubric. Of course, these closely interrelate to each other and interoperate, and that's crucially important to consider. And I'll go through each of these with some evidence for each now. So structural racism, which is reflected in disadvantaged access to a whole range of resources, particularly economic and physical, but also social resources. Deep and persistent inequalities in relation to this, ethnic inequalities in relation to this, and remarkably with little change across generations or across periods in the patterning of those inequalities, remarkably. And this isn't just about material consequences, of course. This also has cultural and ideological dimensions to it. We have to be able to justify the inequalities that we observe in our society, and we justify that through the denigration of those who experience those inequalities. And this, of course, doesn't just happen in relation to race and ethnicity, it also happens in relation to things like lone parenthood and so on. The resulting level of disadvantage, which is hard to measure a cross-sectional way, but also the way in which it accumulates across a life course, which is even harder to measure, makes a substantial, well-documented contribution to ethnic inequalities in health outcomes. Just to illustrate a couple of my points, here is an income chart. These are income tertiles. These are relatively old data, of course. You can see from the quotation at the bottom. But what they do is give an immediate and rapid picture of the extent of inequality across some of the ethnic groups within our society. Because they're tertiles, you'd expect a third to be in each of the coloured segments of each bar. And as you can see, the poorest third increases across the chart. I've already did that way, of course, more or less. With the proportion of the Bangladeshi and Pakistani population in the bottom third of incomes being exceptionally large, and very few of them in the top third of incomes. But that inequality you can see patterned across the chart. And what this attempts to do, this uses census data from 3 censuses. And what it attempts to do is to show that the ethnic inequality and unemployment rate for both men and women, sorry, the bottom of the slide is cut off, men and women aged 25 to 49 has not reduced over those 3 censuses. And remember, these are different generations of people across those 3 censuses with very different historical contexts as well as very different generational experiences. But nevertheless, the height of the bars remains more or less the same. The relative height of the bars remains more or less the same across the 3 observation periods. So deep, persistent economic inequalities. Interpersonal racism, the second category that I want to talk about, which ranges from the everyday slights, the being ignored, being served more slowly, the passing comment, the avoiding to walk past, and so on. The everyday slights through to discrimination in a range of settings, through to actual verbal, physical, and damage to property aggression. This is a form of violence that emphasizes how devalued you are in society, how insecure your status is in society, and not just yours, of course, or the person who's experiencing it, but also all those with similarly racialized identities. So we know racism happens to people like us. It undermines our own status and identity. This generates meaningful psychosocial stress, leads to biological change and damage, which then impacts on health. And again, evidence suggests that there's been very little change in levels of prejudice or in levels of racism over the last 3 decades. I just want to show you a couple of slides in relation to this. This one shows racism and prejudice. The blue line in this slide is an estimate of the proportion of the general population who say they're prejudiced against minority groups, ethnic minority groups. And as you can see, between the period of 1983 to 2013, this has stayed between 30 and 40%. This is a period that goes from 1983 National Front activity, right-wing movements fighting on the streets with ethnic minority people, anti-racist movements, through multiculturalism, to the post-race society, to anti-immigration and Brexit, with very little change despite those political shifts. The orange line and the purple line show fear of racism and experienced racism amongst Pakistani people. And it shows for both of them the rise that happened post the millennium. Of course, Islamophobia was rising before the terrorist incidents of the millennium, but became aggravated afterwards, and you can see that reflected in those charts. The green line and the red line show the experiences for the Black Caribbean population and show that this hasn't changed very much for them. And the grey line shows the decline in racism experienced by Irish people. And you can see how that might reflect both the change in the composition of the Irish population in England and Wales, but perhaps also a change in anti-Irish sentiment as a consequence of the settling or the partial resolving of conflicts in Northern Ireland. What this shows is persistence, as I said, but also it shows even though there is variation across groups, that reflects political context that shapes these experiences to a certain extent. And racism impacts on your health. And I'll show this slide very briefly, but I've got 3 dimensions of racism here: whether you experience harassment, whether you think people will discriminate against people like you, and whether you're fearful of experiencing racism. All of them impact on your health. And there's a large body of evidence now showing this impact longitudinally, cumulatively, and in terms of biological markers. The third bit of racism that I want to talk about is institutional racism, a term that we're all familiar with, but perhaps don't have very strong definitions for, reflected in routine procedures and practices that are embedded in institutional policy that then translate into actions that are conscious or unconscious that negatively shape the experiences of racialized people within institutions. Within the NHS, we see varying degrees of markers of institutional racism. So there are no inequalities in access to GP services, even if you take into account the poorer health of ethnic minority people. There are no inequalities, or very few inequalities, in outcomes of care for conditions that are largely managed in primary care settings. So we've investigated this in relation to how well managed the condition is and whether the condition is undiagnosed, and shown very few, no meaningful differences across different ethnic groups in relation to that. And hypothesize that this is because we have a standardized set of protocols that GPs implement within a setting that is free to access. There are marked inequalities in services that require a fee, dentistry being the example, but there are also very strong signs of institutional racism in other dimensions of NHS practice. And I'll give some examples here. I'll move on to the final few. So we've seen recently evidence on the very high rates of preventable maternal death amongst minority groups, particularly amongst Black mothers. Mismanagement of hemoglobinopathy, such as sickle cell anemia, largely around the perception that Black people don't experience as much pain, or that they are drug addicts. Mental illness, psychiatric services, and the use of the Mental Health Act, with a huge overrepresentation of ethnic minority groups, and again, particularly Black people in secure settings within the mental health sector. And in the context of COVID-19, pulse oximetry, long-standing evidence to suggest that pulse oximetry works less well the darker your skin, nevertheless a routine practice within the care of COVID-19 patients. And vaccination programs, again, long-standing evidence that vaccination programs are less effective at reaching out to ethnic minority populations and white populations, but no attempt to tailor the vaccination programs until moderately recently to address that anticipated, or that should have been anticipated, lower levels of uptake amongst some ethnic minority groups. Give you some further illustrations of institutional racism, just to show how deeply embedded it is in our lives. So this is a person who was involved in a research study that we did around mental illness, where we asked them to take photographs about their lives. And he's shown us 2 photographs. This is the first. To anybody else, these pictures may seem like just a day in the life, but to me, they represent something a lot deeper. This picture with a wonderful sunset in the boardroom is in a building where I speak about my experiences as being a service user and how things can change. I then leave the building, head to my car, and when I come down, I'm stopped by the police as my car has a log on the system stating I'm a forensic mental health patient. It's not that the log is on his system. The log is on their system. It's the fact that he, as a Black man, is much more likely to have that log on the police system. He is much more likely to be stopped by the police. And what it shows is the interweaving of a range of practices of institutions that then shape someone's life in its entirety. What does this all mean for a condition that is age-related? So we now know, of course, that COVID-19 mortality is hugely strongly related to age. And what I'm trying to argue here is that the accumulation of inequality across a life course leads to a widening of health and the premature biological aging of certain ethnic minority groups. And you can see that in these lines. So these are cross-sectional data from the 2011 census. Age groups, level of poor self-reported health, in each of those age groups by ethnic group. And you can see that the lines begin to diverge as we get into middle age and diverge quite dramatically later in life. And you can see that the ethnic minority groups, particularly Pakistani, Bangladeshi and Caribbean, are higher than the white group, which is represented by the black line there. But you can also see, if you look across the orange line, the health of 80 to 89-year-old white people who are at very high risk of mortality from COVID relative to other age groups. And then the age group at which the ethnic minority groups cross that orange line, which gives you some sense of the premature biological and health aging in ethnic minority groups, and then what that means for an age-related condition and increased risk of mortality from that. Well, I'm going to try and conclude. I've got 2 slides to try and conclude, and I'll try and go through them quickly, just so we have some time for discussion. So my argument is racism are fundamental drivers of the observed inequalities in illness and mortality that we see, both in relation to COVID-19, but also in relation to other health outcomes. We need to think about racism and how it operates in our life. And I argue if we think about racism in terms of its structural, interpersonal and institutional dimensions, we can begin to see how it does operate to shape health, but we do need to pay attention to the ways in which they interrelate to each other. So economic disadvantage and interpersonal experiences of racism impact directly on the biology and health of ethnic minority people. But they also shape encounters with institutions that then have a set of policies and practices that amplify ethnic disadvantage. And this isn't just about health, it's about a whole range of institutions, from education through to politics. Institutional settings are the places where the concentration of disadvantage can occur. You bring into those institutional settings your socioeconomic disadvantage, your experiences of racism and discrimination, and then they are amplified within those settings. And as I argue, this is both overt and unwitting agency. But because of that, institutional settings may be the places where we can achieve great change in terms of ethnic inequality. So that's the positive dimension of my talk, is that if we focus on institutions, then we can change what's happening to ethnic minority people in our societies. But we also need to think about what institutions are doing, and therefore how institutional racism operates. So how it operates in relation to vaccination will be quite different from how it operates in relation to the sectioning of people with severe mental illness. What does this mean in terms of policy? So I've headed this slide the failure of policy, and I believe we've seen a dramatic failure of policy in relation to COVID-19. Ethnic differences in COVID-19 mortality should not have been unexpected. I argue they were treated as though they were unexpected. There was no policy preparation for this. They could and should have been anticipated. I also argue that policy is poorly informed. There's been no serious policy investigation of ethnic inequalities in health since the HSN inquiry of the late 1990s. None of the other inquiries have taken the same fundamental examination of ethnic inequalities and what might be driving them. As a consequence, people who are working in this field, both as analysts and as people developing policy, really do not have the theoretical tools, the critical tools, to enable them to thoroughly investigate their data in terms of trying to understand cause and then response. Best explanatory approaches focus on those things that many empirical investigators, including myself, focus on: socioeconomic distribution and so on. The things that might increase exposure to infection and the consequences of infection at a proximal level. At worst, of course, a lot of explanations move towards trying to identify the genetic, the cultural, and so on, as centralized emic understandings, common sense understandings of what ethnicity is, in order to make sense of this. I argue, of course, that we need to do the more difficult thing, which is to examine how these inequalities result from the ways in which people's lives are shaped by experiences of racism. And my final point in terms of this, coming back to one of my very early points, is that we need to do this now in relation to exit from the pandemic. Assuming exit continues, we need to think very clearly and carefully about the unequal outcomes that have come both from lockdown, but also from the consequences of lockdown as we exit out the pandemic. Right, I'm going to end with an advert, which is here. So the Centre on Dynamics of Ethnicity, which was mentioned earlier, is involved in this study called EVENS, which is a large survey of ethnic minority people during the COVID pandemic. And what I would like is for you to take a note of Even Survey, of the social media, hashtags, promote it, encourage people to take part in it. Okay, that's all I have to say. Thank you very much for your attention.
Thank you, James. This is a very interesting talk. To be honest, I came from a medical statistics background. Therefore, this is a very novel piece of knowledge for me. So I don't really have a question, but I would like you to talk a bit more, because you have pointed out that there is an inequality in different ethnic group. And you said the government policy made so far has had little consideration on this. Can you give me a little bit more example on, for example, so this policy can be improved if we consider something more, so that I can link your general introduction of knowledge with the detailed circumstances.
Yeah, absolutely. So if you think of the policies that have been designed to protect people's employment, so furlough is the obvious one, but there are also others around social distancing and so on. And then you think of the economic sectors and the types of employment that certain ethnic minority groups are more likely to experience, and either the ways in which those policies do not protect them because of their precarious employment, or do not protect them because of their low wages and therefore their need to continue to work in relatively hazardous conditions, or in the early days of the pandemic, the ways in which PPE was distributed across different sectors of the health and social care workforce. In each of those cases, ethnic minority people are at a disadvantaged situation, and the policies assume that everybody is equally advantaged. And so you then need to think about the ways in which policies can be implemented to protect the taxi driver as effectively, or the bus driver as effectively as where ethnic minority people are more concentrated as some other service occupation. So that's one example. You can also think then about the more immediate examples that I briefly offered. One is pulse oximetry. We knew pulse oximetry did not work so well with people with darker skins. We knew that. We didn't pay any attention to that when we implemented mass pulse oximetry to monitor who needs acute clinical care and who doesn't. We knew that. And now I don't know what the consequences of that were, but we certainly know that that was a big risk. And the same with vaccination. So if you take my chart on age, then at one level, the decision from the vaccine committee to implement vaccinations according to age makes complete sense. But if you take my chart on age, it doesn't make sense in relation to ethnicity, because biological age doesn't equate to a chronological age in the same way as it does for white people. So then you can think, are there other ways in which the vaccine can be got to ethnic minority people? And then you can also think about the fact that we knew about poorer access to vaccines prior to the pandemic. Lots of evidence in relation to that, to flu vaccination. Why was that not paid attention to as vaccine distribution started? So those are just some examples. There are many, of course, that I could offer, but I've already spoken for way too long.
Oh, thank you, James. This is great to listen to these explanations. Now we have a question for James from Sean. So how do you think researchers, for example, the trialist such as Sean himself, should record information to ethnicity so that we can explore differences in the acceptability in the treatment to different ethnic groups, whether some groups are not receiving it, so because they will gain no benefit should the treatment provide benefit?
Yeah. So I think of a number of dimensions, but I think crucially, I am to a large extent a survey researcher, and as a consequence, I use the census categories as used in the various censuses as they've evolved over time since 1991. And I think they are, although we complain about the heterogeneity within particular groups within the census approach. I think they are robust, they work well, they seem to be consistent over time, and they are, the methodology to develop them is kind of really very strong. So I think they're good survey instruments, but there are other dimensions of ethnicity that are important, of course. So I think religion is also important, and the way in which Jewish people are absent from many surveys of ethnic minority people, I think, is a reflection of a kind of refusal to capture religion in some of these data sets and to oversample Jewish people. So I think religion is also crucial. We could also begin to measure ways in which people experience and practice their identity. So the cultural practices they engage in, and there are standardized questions for that. If you look at the EVEN survey, which I just tried to publicize, you'll see measures of all of these things. And then the third thing, of course, is experiences of, the fourth thing, of course, is experiences of racism, which I don't think we can begin to understand what's happening to ethnic minority people unless we begin to measure their experiences of racism.
Any other questions, everybody? So Mikhail raised hands. Mikhail, are you there?
Yes, hello, good afternoon. James, firstly, you must say a really great presentation. This question is pretty much joint between yourself and Vahe, actually. So considering what you had stated in regards to racism, I believe that one of the things that potentially could have improved the quality of the data in regards to what Vahe had presented, linking it with what you had presented, was that if we had considered the cultural differences in regards to level or access to information. So your data, James, for example, clearly stated that when it goes to the older generations, then there's a greater disparity in regards to the access to vaccinations. Then I clearly believe that from that standpoint, because genuinely ethnic minority, older generations are usually far more likely to be the immigrants to the UK, then they're far less likely to have a firm grasp of the high level technical knowledge that would have been presented, for example, in a number of these medical briefs that are given on a daily basis. So I think if it is that they were able to engage or have interpreters from those GP practices that would have been engaging with that older generation, then that potentially could have increased the uptake. And then that links now with your with the data that you presented, Vahe. Did you consider the impact of potential misinformation as to how that would have reflected within your data in regards to the vaccination uptake? Because surely for a number of these older generations, they usually tend to more communicate within their own micro socioeconomic group or micro community groups, and thereby the information that they'd be spreading would be within their own languages and not necessarily engaging with English language, which would be their second language, especially for the older population.
Should I go first, James?
Yeah, you go first.
Yeah. So no, it's a very good point. It is likely that it is one of the pathways that explain the differences that we observe. In terms of doing anything from a statistical point of view, what we did was to look at exploit a bit more the information we have in the census on the main language and on the country of birth, which we could look at, and we indeed found very strong differences in vaccination rates by proficiency, by English language proficiency, and by country of birth as well. And I don't think we've published that yet, but when you adjust for these, the ethnic differences, the odds ratios are reduced by quite significantly. So it is probably, so this kind of, it's an indirect evidence probably that that misinformation is likely to be a pathway. But unfortunately, from a purely analytical point of view like this, there isn't a great deal we can do without having information. I mean, I think what you would really need is, I like the need for a survey, I think, to collect, to do a deeper analysis. I think that you highlight the limitation of what you can do with administrative data. As you can identify patterns, when you want to explain them, it's much harder to do so. So I think, a good survey would probably be important. The most problem with surveys here is the response rate. You would probably see that you'd have a problem of reaching some people are really hard to reach, and there are also probably the people who are less likely to respond to get vaccinated. So you probably struggle to find that. I hope it answers to an extent your question you heard.
It gives me an opportunity also to publicize the Even survey again. Look at that. Look at their social media accounting of that and promote it, because one of the things we are doing is trying to get to the hard to reach, or the hard to listen to, perhaps is a better way to describe it, groups in our society, including travellers, for example, and older people. And of course, access to information is crucial when you want to do a health promotion campaign. And what I guess is frustrating is that this was recognised as an issue too late in many respects. But it is something that is happening more now. So there's much more, I think you mentioned this, Vahe, there's much more community embedded promotion of vaccination that includes paying attention to things like language, paying attention to the places that people would like to go to get their vaccines and so on. But certainly when the vaccine program was initiated, attention hadn't been paid to those things.
Okay, so we have time for one final question from Sad. So Sad asked, can we make a link of these two research that inequalities arises from racism?
So I would argue we can. Of course, the kind of work that Vahe and others in the ONS are doing relies on the data that are available to them, which then limits, you have data from 2011 to measure socioeconomic position, for example. So you do have to make compromises, but you use the data that you've got in order to do something that is constructive and that helps us think about solutions to problems. And of course, the measures that Vahe shows, I'm not sure, I'm speaking to you a little bit, I'm sorry, but the measures that are included, of course, reflect some of the dimensions that I theorize relate to experiences of different types of racism. So socioeconomic position, where people live and stuff like that. So I think you can make direct links. And what you can also do is build on that kind of analysis with other data sources to begin to explore other dimensions of the kind of things that I theorize are important. But I think what's crucial from my point of view is whether you like the theoretical approach that I'm offering or not, that you do start from a theoretical approach and begin to operationalize concepts that within the data sources that you have to begin to test theory, which then helps explanation, which then helps policy.
Yeah, I agree with James. I mean, some of the factors that we include in our models would relate to structural racism. I mean, all the differences in social demographic, socioeconomic characteristics, I guess, could be seen. I guess the temptation, you could have the temptation to explain the residuals differences as racism, again, as maybe different types of racism. But again, I would be quite cautious of doing this because of the way the factors we include are mismeasured to an extent because they come from the 2011 census. And therefore, it could be that we understate their explanatory power. So maybe the factors related to structural racism explain more than we actually see.
Yeah, so I would agree with that very strongly as well. So I, very early in my work around ethnicity, I argued that the residual is not some redundant ethnic factor.
Yeah,
whether that's genetic, cultural, or something else. We have to accept that these are empirical models, and empirical models carry imperfect measurement.
Yeah.
And so we need to be very cautious in explaining observed variance with unobserved factors.
Yeah, that's what we try to.
Variance, I mean, yeah.
No, we try to say this model explains 70 to 80, sometimes 90% of the observed risk. The difference in risk is a lot for an empirical model to explain. So it does suggest that these factors is quite a lot.
Okay, so due to time constraint, we have to stop here. Thank you for Vahe and James for your wonderful, wonderful talk. And thank you everybody for your audience.
Thank you for sharing. Good job.
Yes, thank you very much for the invitation.
Thank you very much. It was great to have the opportunity to present here. Bye.
Great. Bye. Have a nice day.